This podcast is sponsored by BetterHelp. After experiencing trauma, I went to therapy, and my therapist guided me through a difficult time in my life. They helped me understand what was happening and provided me with tools to cope and find my own strength and resilience. Their experience and compassion were invaluable and enabled me to rebuild my life and move forward. I strongly believe in the power of therapy to help people through difficult times. BetterHelp connects you with a licensed therapist who is trained to listen and give you helpful, unbiased advice. First, you go to their site. You can use my link, betterhelp.com/resilience. You answer a few questions, and BetterHelp will match you to a professional who has years of experience helping people with struggles just like yours. Let BetterHelp connect you to a therapist who can support you, all from the comfort of your own home. Visit betterhelp.com/resilience or choose podcast, then notes on resilience during sign up and enjoy a special discount on your first month.
What is going to do the least amount of harm? That's always the question. What will do the least amount of harm? What has the best strategy to help the most amount of people and lay the groundwork for not just creating a Band-Aid on something, but how can we actually iterate and make something that's more of a systematic potential change or throughput for patient.
Hello, and welcome to Notes on Resilience. I'm your host, Manya Chilinsky. My guest today is Dr. Heidi Steinecker. She is a distinguished public health leader with decades of experience in healthcare delivery systems and public health policy, and she has served as a U.S. citizen diplomat for the U.S. Department of State and the Deputy Director of the California Department of Public Health, and she's a principal at Resultant Consulting. We had a wonderful conversation about a difficult topic, which is crisis management and how to lead when a crisis is occurring. I think you're really going to learn a lot. Heidi, I'm so glad that we got this chance to talk today. Thank you for being here.
Absolutely. I'm excited for the conversation.
All right. To get us started, what is one thing that you've done in any area of your life that you never thought you would do?
So many to choose from. However, I would say getting to be able to do citizen diplomacy for sure. Being able to meet with heads of state, ambassadors, ministries of health, whole cabinet sometimes. I met with the entire parliament of Kosovo once when they were trying to design a new healthcare system. That piece of the puzzle was not on my bingo card growing up.
Yes, I probably isn't on many people's bingo card, but that's so cool. I imagine you have so many stories connected to those experiences.
Yes, and both domestic and abroad, just experiences in that space where when you think of healthcare as a rural student growing up in a rural area, which is where I grew up in rural California, I was more really focused on access to care. Then later on in my career, I was more focused on quality of care. And then I fell in love with this kind of juxtaposition where the intersection of healthcare and government meet and understanding how whatever happens in one little corner of the world has its way of working its way over to another corner of the world. And so all things that happen locally end up global, and all things that are global impact local communities. And seeing that there is that really important intersection between diplomacy, relationships, data sharing, all of those things keep all of us safe.
Yes. Wow. That's so amazing. And I just love the sound of the work that you do. And like you said, the local piece and this global piece. And I'm a little envious of the kinds of experiences you've had. Well, thank you for sharing that. And today we're talking about crisis management and sort of proactive strategies during a crisis, because I know you, in your public health role, have dealt with some big crises that I think we would all recognize. Just to get us started, how would you define what strong leadership is during a crisis?
Well, I can perfectly define that as something I was actually accused of once, of being too calm and collected by a senator during a hearing, debriefing on a crisis. And I was accused of being too calm, collected, and, really rational with my approach of how we were going to go through something rather than showing up to the testimony unhinged. And so when I was accused of looking on feeling for the thousands who were dying, not only did I make it clear to that senator that I had lost a family member to COVID during the pandemic in a facility that was partially all of my responsibility for the entire state. So of course I had personal feelings and fears and things, but when you are a leader, you need to compartmentalize. You need to be able to focus on your team. You need to focus on what you can do, not what you can't do, and constantly get your team to be motivated, inspired to just get up one more day and do one more task, one more purpose-driven mission, piece of the puzzle that they have a piece of. And that's your job as a leader during a crisis.
Right. Interesting that there was criticism of your being a strong leader. I imagine there would have been criticism had you come in a panic and overly, or not overly, but emotional about the situation.
Of course, in my mind, my immediate thing that was running through my mind was, I don't think you would ask a male leader the same question. I refrained.
I am fairly certain you are correct. Exactly. I think we may have uncovered part of the challenge here with that, which is probably not a surprise to most of our female listeners. What is the first thing to look for in a leader's response when a crisis hits, whether you're male or female, and whether you're asking the questions for some other reason or not? What is the first thing we should be looking for in leadership?
So the first thing I look to is visibility of what the scope of the issue and the potential forecasting of the problem can be. I look at it as a chess match, right? Not as what is currently occurring at the time, but in addition to that, what are going to be the downstream effects that we need to be looking for in the next hours, days, weeks, etc. And with that, to have visibility, I need as much real-time data as possible. And real-time quantitative data is already kind of difficult to get sometimes because you don't have in a health situation, you need real-time understanding of where the bed capacity is, different acuity levels, different things, different types of facilities that you may need to evacuate or repopulate or transfer patients that are really critical and non-ambulatory, as well as which locations can you maybe be able to bolster and shelter in place. And those are all very kind of quick decisions you have to make based off of the information you have at the time. And so a leader needs to be comfortable making difficult decisions with the information you have at the time, and then constantly being able to iterate and communicate the why between those shifts.
Wow. As you were describing that, I was thinking that one also has to have a lot of presence of mind to understand, okay, this is what's happening in the moment and it's important, but I have to be thinking 1 to 12 steps down the line of what could be happening. And you can't predict the future, so you have to make some guesses.
I would say educated guesses, right? Or estimates, right? Luckily, when we're dealing with science, it's often a math equation, right? So you can run different estimates based off of math and modules. I also like to work with fantastic data scientists who can run algorithms and risk algorithms based off of where we think that there are different weights of kind of root causes that could cause different scenarios to happen. So there's a lot that we can do now with predictive analytics. There's a lot of things that we can do for quicker decision making based off of mathematical models. And in addition to that, I would like to say, because I think it's so important, I'm a mixed method research person, the fact that you can run risk models, you can be able to have an idea of where you think you're going to have highest risk locations to be able to intercede or mitigate quickly. But nothing replaces that qualitative data from being boots on the ground, getting that intel from your teams on the ground, flying in or driving in or whatever yourself to get to that location as well, to interview and understand the nuances and the context of what's creating those maybe quantitative measures that you're looking at. So you can't just look at one piece of the puzzle. You do have to be able to get more local context and community and cultural context of what's happening in that particular area that you're trying to mitigate.
Right. And you mentioned your research background and that you like to work with data scientists. If we're average company leader and suddenly dealing with something you never expected, you probably don't have access to that data scientist. So then that boots on the ground experience becomes much more important.
Absolutely. I mean, I even spent last summer living in Uganda, in rural Uganda, on the border of the DRC and Rwanda in the Burundi impenetrable forest. That is the location, is what epidemiologists like to call a hot zone in the world. It's a location where you have multiple different types of diseases, everything from HIV, malaria, dengue, cholera, monkeypox, Ebola, you name it, it's going to come out of this region for multiple reasons of great biodiversity. However, you don't always have all of the same tools in the toolbox to be able to mitigate in these high risk locations. So you have to be really creative, really collaborative, building trust with the local community and the cultures that are at play there. If you're going to have any kind of protection of your healthcare facilities, to be able to, as these diseases are coming into your facility, to be able to quickly cohort and contain, that you don't have mass outbreaks.
Right. And one thing you said there really sticks with me, which is building trust in the community and doing that before you need to reach out, before the crisis hits and you need to figure out what's going on the ground or you need help. And I think that's a lesson that's transferable across industries, across locations. It's all about building those relationships.
Absolutely. And I think that is the key that is missing so often. And people want to build really cool tools. They want to do mobile applications. They want to be able to have more modern surveillance tools. And that's fantastic, and absolutely agree with that. But you have to start with the people first. You have to start with the relationship building first. You have to build that trust so that you can be able to have focus groups and communities that want to use this. You do have staff who want to be able to buy in and be able to have real-time information at their fingertips. You do have to be able to have partnerships to be able to understand how different data sets interplay and be willing to have data sharing agreements for using access to data in a good way. For example, even in California, when I was serving CDPH, the Department of Public Health, we were starting to figure out that, oh, in all of our risk data algorithms, it didn't account for, all of these childcare centers that were around skilled nursing facilities. And all of the healthcare workers working in skilled nursing facilities are around childbearing age. So we started to reach out to our friends in social services and say, hey, you have all the data of outbreaks in childcare centers. Would you be willing to share it with us? And this is the goal that we have in mind, because we have this hunch of correlation here. And sure enough, because we had an established relationship, they shared that data into our risk algorithm, and we were able to definitely see that there was, within a 5-mile radius of a skilled nursing facility, if there was an outbreak in a local childcare facility, that there would be an outbreak in that skilled nursing facility following a few days later.
Well, and as you mentioned, it's so important to have built those relationships and be asking the people on the ground what they care about and what matters to them. Because I think there is often, or perhaps not often, there's sometimes a desire to, we know X, we're going to do this because it's the right way to do it. Usually, I think those don't end up to really be the best ways. Hi, it's Manya. You're listening to Notes on Resilience, conversations about leadership, recovery, and how we show up in the difficult moments. If something here hits home, or if you're navigating a crisis, or you're seeing something in your team you want to talk through, I'd love to hear from you. You can get in touch at my website, manyachilinsky.com. Now, back to the episode.
Absolutely. Completely agree. And each community is going to be very, very different, right? And we have a lot of rural communities in the US that will be drastically impacted by the passing of the Big Beautiful Bill and the cuts of Medicaid, because a lot of our healthcare facilities in rural locations are dependent on that payer mix. And I see that there's a lot of things that I learned in working in rural Uganda as far as these relationships and consolidations and creative ways that they can help each other could be ways that we can start to look at how can we prepare ourselves to make sure that we maintain access to care in our rural communities here.
Right. Because that, which by the way, I refer to it as the big ugly bill, but that itself is creating a crisis that will need to be responded to.
Absolutely. Absolutely.
So when we're thinking about a crisis, I know when I talk about it, I'm often thinking of an incident that happens at a moment in time versus something ongoing like COVID, which lasted for a while, and the impact we're about to see on our rural communities, which is going to last for a while. As a leader, how does someone balance the urgency of that response with the need to really kind of listen and reflect and take a moment before making some of those big decisions?
It's a great question because you don't want to be having analysis paralysis, right? You don't want to also be waiting because sometimes, then again, the information is shifting constantly. And there are certain things like wildfires, earthquakes, anthrax outbreaks, things that come across the border. We've had multiple different issues of crises, even something as simple as, oh, there was a utility breakdown in a hospital and they don't have water for 48 hours, right? So it can be something small and very, very localized or something really spread. But regardless, it's taking that time to think through, okay, what is going to do the least amount of harm? That's always the question. What will do the least amount of harm? What has the best strategy to help the most amount of people and lay the groundwork for not just creating a band-aid on something, but how can we actually iterate and make something that's more of a systematic potential change or throughput for patients? Because it's a whole continuum, right? I know a lot of people think of hospitals when they think of, oh, a healthcare crisis or that, and they forget that there's actually 38 different types of healthcare facilities in the US. And they're all licensed and regulated differently. They all serve a different niche of our healthcare delivery system. And some of them are less seen as healthcare, but more of different types of centers to provide care for individuals who are vulnerable and unable to care for themselves.
Right. It's, you said something that was so interesting to me. What's going to do the least amount of harm? As a civilian, when something goes wrong and looking to leaders like yourself and others who are managing the response, I think there's an expectation that there's somehow a single right answer that's going to protect everyone. And then it's hard as a civilian to be watching this and realize that the best answer, the best response, isn't necessarily one that is going to protect everyone.
And that's unfortunately the case sometimes, especially if something is widespread, right? You are hoping to be able to protect those who are the most vulnerable to whatever that particular situation is, right? And so if it's an infectious disease, you're able to know often what the pathogen attacks, how it transmits, and who is more susceptible to it, right? So you kind of have that information. If it's a natural disaster, you are looking at the radius of that natural disaster. If it's an earthquake, of course, you're looking at, seismic radius to see what are the different types of licensed facilities or facilities that have people in them that can't just up and move, right? People who, for whatever reason, whether they live on their self by themselves or they're living in a facility, they can't just ambulate and just move to another location easily, right? So that's what you're targeting in that case. When it's wildfires and or hurricanes, we have sometimes a path trajectory that we can tell based off of wind, but that can also constantly shift.
Yes. The other thing, speaking of constantly shifting, in a crisis, and we saw this a lot during COVID for sure, is we learn things. And so the response today is shaped by what happened yesterday. And again, as a civilian out in the world, it can be so hard to understand that something you said was true last week actually isn't true this week. And because, or this, what was true an hour ago isn't true now. And when you're involved in a crisis and you're in a leadership position, how do you manage that information can be changing really quickly, and it can be very difficult for people to understand that that is happening?
Absolutely, communication is the number one factor in moving a population toward the information they need to be able to make decisions for themselves. And that is one area that, unfortunately, I would say during the pandemic was a lesson learned for all of us who work in science and leadership, because it was taken for granted, I think, throughout the 80s and 90s, like 70s, 80s, and 90s. You just had these kind of campaigns that, yeah, of course, everyone gets vaccinated, everyone washes their hands, everyone does this. Infectious disease kind of fell away as a priority at that time period in the US, and we had focused more on chronic disease because of all of the efforts in the 40s, 50s, and 60s. We had cured or contained most of infectious diseases. So other than AIDS that came up in, 80s and 90s, and we then again found ways to mitigate for that. And so there wasn't a new novel pathogen in a while that had been one of those things that an average American citizen would have been concerned with. And we hadn't updated any of our approaches for how we communicate around infectious disease in years either. It was, oh, you just go and do it, right? You just go do what you're supposed to do, right? And we needed to put more of an emphasis on the why and explaining quickly how and why this is shifting in real time. And it didn't help that we had conflicting messages coming out from the federal government versus whatever state government you were working with, right? So you had a lot of conflict there when it came to information. But it's interesting, when I was in Uganda last summer, and we did a vaccination clinic in a village on the DRC border. And this is a location where they do not have a written language. So you actually have to go out there, stand in their city center in scrubs. And then that lets everyone know that today is the day for vaccines, and it travels by word of mouth. And they will walk miles barefoot to get to you to get all of their shots. And so we did HIV testing, screening, treatment, and vaccinations for kids. And we vaccinated over 100 families that day, just all day long. And one of the nurses came up to me and said, "Yeah, so you're from America, right?" And I said, "Yeah." She says, "Is it true what I heard in the news that there's Americans who wouldn't want these diseases that save your life?" And I said, "Yeah, it is true." And she goes, "But why? Haven't they seen someone die of polio? Haven't they seen how deadly, you can die of this, this, and this?" And I said, "Sadly, no, they hadn't. They hadn't seen it in decades." And then the next question she had was so telling. She said, "But you must have elders who had. Didn't you have your elders talk to everyone about experiencing what measles, mumps, rubella was, or all of these things?" And I thought, you know what? We didn't. For decades, we just told people, go do it. This is what you do. We never did share those stories of our grandparents or people from other generations who had witnessed and experienced or lived a life in a wheelchair from polio. Like we never did a great job of explaining and carrying that information on. So people thought it was eradicated and no longer needed.
Right. And when you think about vaccines, for most of us, most vaccines were already existing when we got to the point where we needed to get them or we learned about them. So we didn't go through that process of watching them be tested and having to deal with what does that mean. And so, wow, that's so telling, though, that it's something that people here weren't thinking about in the same way, and how grateful they were clearly for the opportunity to get this. Wow. Thank you for sharing that. So, in a crisis situation, and whether it's something that plays out over a long time or it's kind of instantaneous. How do you move from being reactive and trying to deal with, okay, this is happening now, to that recovery piece of, okay, now we've got to deal with this for the long term and the immediate crisis is over or it's slowing down and we need to think about the future?
So I think there's a step in between that reactive and response that I like to try to insert is how can we be proactive in ending the heights of the issue sooner? So first you're reacting, right, with the information you have. Once you get enough information, you can start to take pieces of the puzzle and be like, okay, so we think this is going here, or we think that it's going to now have a downstream effect to these locations or people here. What can we do to bolster them and provide them resources to mitigate in advance to end it sooner, whether that is natural disaster or infectious disease. And then when you move past, when you get a handle of kind of stopping the progression or slowing it, then that recovery piece, I think there's a big piece with crisis management that people forget is the emotional piece. So many, whether you are the responders or people who are mitigating the situation, or you're the heroes who are the active service players in that piece of the crisis, or you're the victim or citizen who was impacted. And sometimes you're both. Sometimes you're both a respondent and a victim. There is this emotional piece to it that people have to grapple with, because in the moment, and many responders particularly are trained to be able to be calm, cool, collected, handle things, help people move things along. They're very focused on fixing and mitigating the situation at the moment. After the fact, when there's a moment of pause and you see the level of devastation to whomever it is, that's when a lot of folks who are responding sometimes go, could I have saved more people? I mean, I always call it like the Schindler List moment, where, at the end of Schindler's List, where he's crying and says, I could have saved more. It is that feeling that many different folks in either leadership or government positions or response or crisis management positions have that moment of, what could we have done more, right? And that's good, because you iterate on these after actions. You purposely are looking at after action reports, thinking how you could do it differently, and focused on that. But also, I think it's important that there needs to also be some self recovery as well, for folks to be able to truly kind of be as present as they need to be during the next stage.
Yes. And I think it's easy to overlook that or decide it's not important in the moment, in terms of, we got to continue the response. We have to keep helping people. I don't need to take a break unless you are in a formal, if you are a first responder or you're in a crisis management firm, then they often have those steps of, you have to step away and take a break after X amount of days, what have you. If you're not in an organization that requires you to step away, I think it's hard for people to step away until they have to.
Yeah, absolutely. Absolutely. We started to have to institute during the pandemic, because, all of us were service-oriented leaders, and we realized that it had been months since no one had taken an hour or so or a day off, like it was 7 days a week. I mean, every single weekend, you were missing every holiday, you were missing every birthday, everything, right? And it wasn't until as we neared the holidays, they said, okay, we're going to start mandating, all right, this person's going to take a Saturday off. This person's going to take a Sunday off. This person's going to take a Monday off, like, and rotate it around to force people off their, like, don't even pick up your state phone. Like, you are off, and you have someone who is handling your duties for that day, and have a whole process for how you are going to offload your authority, whether it was your decision-making authority or whether it was your staff or whatever project or piece of the puzzle you were put on.
That was very important, and I'm sure that it wasn't enough for the amount of work that folks were putting in, but at least it was something, a little chance to get a break. Heidi, we're coming up to the end of our time, and I want to talk to you forever. But I promised my listeners that we're going to go about a half an hour. So can you tell us a little bit about yourself and the work you do? and how folks can reach you.
Absolutely. Well, folks can always reach me on LinkedIn. I am very present there and always happy to have a conversation whenever people direct message me and say, hey, heard your podcast and would love to connect. And so I'm always happy to do that. A little bit about me. Grew up in rural California and spent my first part of my career in health on the healthcare side, everything from operations, regulatory, quality and safety. Did a brief stint over abroad in Germany, working with them as they were bringing in all their Syrian refugees and needing a process for surging their healthcare systems during that time. Came back and served both Governor Brown and Governor Newsom as the deputy and authority over a healthcare system for public health, and stayed in that role throughout until after we had the vaccine rollout in 2021. And since then, I have both been serving as a U.S. citizen diplomat for Department of State, as well as a consultant who's worked with many different states and countries, and just love to see where I can help different governments to be able to think through complex problems and trying to be able to put data and policy and operations together to where they can be able to work on their crisis management.
Wow. Wow, that's so amazing. Thank you for sharing. And as the final wrap up question, what is giving you hope these days?
What's giving me hope is the next generation. I see the next generation of leaders or starting or workforce starting to enter, and they're not deterred by whatever else is going on. And having that fresh level of enthusiasm is important to infuse into a workforce, and also creative about how they can be able to use different tools that we didn't grow up with, right? To be able to infuse into our government systems.
Wow. Well, thank you so much, Heidi. It was such a pleasure to talk to you today. I really appreciate you making the time.
Thank you so much for having me. It was great talking with you.
Thank you. And thank you to our listeners for listening to this episode of Notes on Resilience. We will catch you next time.